Hello, my name is Dr. Kim Van Orden, and I'm a member of the Ranch Outcomes Advisory Group. And I'm sorry I can't join you in person, but am grateful for technology to allow us to be together in this way. I'm going to be talking to you today about some program evaluation that I worked with the other members of the group and Lynn Pilcher on. So a little bit about me so you know who you are listening to. I am a clinical psychologist by training. Currently, I'm an associate professor in the Department of Psychiatry at the University of Rochester Medical Center. But back in 2002 to 2003, I was a house advisor. And you can see there how young I was. Those are photos of my time at the ranch taken by my friend Gretchen Gould. The one on the left, I think I was entranced by our new piglets. On the right, there's me with Rebecca Swisher, and we were so excited by the lambs. So Lynn invited me to be part of this group because I have expertise in analyzing data, but I also have some context for interpreting the data given my time at the ranch, which was one of the best years of my life. So I'm very happy to be able to support the ranch in this way and hopefully use some of my talents to give back to a place that has given so much to me. So what I'd like to talk about today are four things. First, just to get us on the same page about what is program evaluation, some different definitions of terms so you can know how I'm using them. Then I'm going to present some data to you on the outcomes that we would refer to as looking at functioning. And this will be data from the Daily Living Activities Rating Scale. Then I'm going to tell you some about satisfaction outcomes. So how satisfied are residents and their family? And then I'll talk a little bit about future directions, but mostly I'm going to hand that off to Lynn to talk about and engage with you all in a conversation about what to do with this information, where to go from here. So what is program evaluation? The definitions that I have for you here are those used by the Centers for Disease Control and Prevention, their Office of Policy, Performance, and Evaluation. After the pandemic, most of us are pretty familiar with the CDC, but they've been doing this a long time, and they have a pretty good working definition of program evaluation. So the first term we need to be on the same page about is what is a program. So a program is any set of related activities that are undertaken to achieve an intended outcome. So for our purposes, when we talk about the term program and program evaluation, I'm talking about the ranch. I'm talking about all the activities that residents do and all the services they receive while on the hill. And then evaluation, what's that? Well, what we mean there is a systematic method for collecting, analyzing, and then using data to examine effectiveness, meaning how well a program works, and also how efficient it is, and importantly, to contribute to continuous program improvement. So we want to take data and then we want to learn from it, and we want to make a program better. Now, how this differs from research is both research and program evaluation use data, but the goal of research is to produce generalizable knowledge. So if someone were to collect data on the ranch and how it goes for residents for research, they would want to be understanding therapeutic communities in general. And they would want their data to generalize beyond the ranch. Program evaluation, in contrast, is much more practical. It's geared to help you all at the ranch improve things or whatever questions you want to answer about your program. And so it's much more focused. And so the way you do things might be a little bit different. We don't need to go into great detail there, but it helps to understand what program evaluation is by also considering what it isn't. So the next slide I have for you is talking about, well, now that we know what program evaluation is, what does it involve? So again, this model is adapted from the CDC model, somewhat simplified to make it better fit our purposes. I'll briefly describe the model to you. So the idea is that there are 5 stages, but they're iterative. So it's an ongoing process. That's why it's a cycle. So in the first step, you want to engage stakeholders, including those involved in the program operations, those who may be served by the program, like the residents, and primary users of the evaluation as well. And I'll describe on the next slide how Lynn got that process going. The second is to get specific about the program you're evaluating, as well as the goal of the evaluation. This is an aspect of the program evaluation that I think we could continue to improve, because the idea, we know what the ranch is and what you all do, but have we really specified how we think the program works? So creating a logic model where you lay out the different components of the programming at the ranch and specify how it might help. That can guide the questions that you might ask residents and family members, things that you might observe. And so that may be one place to grow in the next iteration of evaluation. Now, the third step is gathering data. And so the idea is not just any data, but data that will be credible. So I'll talk about the different pieces of data that we had to work with evaluation and the things about it that made them credible, and that can strengthen your conclusions and faith in whatever conclusions you draw from the data. So the fourth step being justify conclusions. Now that means linking any conclusions you make back to the data. So you can show, it's kind of like if you were, doing math as a kid, you have to show your work. Just the same here. You have to show how whatever conclusion you make is supported by the data. And then finally, share lessons learned and continue the process on. So that's part of what we're doing today. We're sharing what we've learned, not as an end product, but as a beginning, as a place to start this conversation. Okay, so moving on, I'm going to try to illustrate what we've done thus far by linking it back to that model and the step that we are talking about. So steps 1 and 2 are represented in this slide. And what you see here are the scope and purpose of the Outcomes Advisory Group. And this is sort of a mission statement that Lynn drafted, and that the group, you can see initial members on the bottom. We agreed that this makes a lot of sense. And so the goal was to think about overseeing the design, development, and dissemination of the outcomes program. And the focus is program evaluation and then quality improvement. And so the idea would be to use data that's already collected, and then also come up with recommendations for additional areas of focus. And so the idea is to use data collection to improve outcomes, and also to be able to quantify and show other people kind of what we know, the magic of the ranch. How do we share that in ways that make sense to individuals who may not know things about the ranch? So step 3, that's collect data. And so this is something that Lynn had started, several years ago now, which is to start collecting data on how residents are doing on admission, and then how they do at discharge. Because a big focus of the ranch is on recovery. It's on wellness and improving in recovery and functioning. The measure that was selected was the daily living activities for adult mental health. And throughout the presentation, that will be abbreviated as DLA 20. It's called the DLA 20 because that stands for daily living activities. Those are like activities of daily living. And then the 20 is that they're 20 items. So the DLA 20 is a 20-item observer rated scale. And so that means that it's not report from the residents themselves. It was staff at the ranch who were able to rate individuals. And that's a common method of getting functioning data, meaning how well someone is doing at work or or in whatever role they're in, like a student, for example, and as well how they're doing and taking care of themselves from day to day. So 20 domains of functioning relevant to recovery from severe mental illness. So this rating scale was developed with the individuals who are likely to come to the ranch with that population in mind. It was designed to be brief. It was designed to be easy to administrate without a ton of training required. So individuals without extensive mental health backgrounds can administer this reliably. And so one thing I want to point out is how each domain is rated. So there are 20 items, and each of them is rated from 1 to 7. So a lower score indicates lower levels of functioning, whereas a higher score indicates higher functioning. So a higher score is better. And so the developers of this scale suggested the interpretation that you see at the bottom of this slide. So a level of functioning of 1, if someone was rated as a 1 on a domain, that would be considered extremely severe functional impairment. A LOF of 2, and I'll be abbreviating that, a level of functioning as LOF, of 2 would be serious to severe, 3 would be moderate, 4 would be mild, and 5 or above, from 5 to 7, would indicate no difficulty. It's important to keep in mind that those different levels, 1 to 7, are referencing the population of adults with severe mental illness. So we know that severe mental illness impacts functioning in a pretty major way. And so the idea is that we're not comparing this to individuals who don't have an illness. We're comparing it to individuals with SMI, which means that we might take the different numbers into account when we think about that. So the comparison group is important to keep in mind here. Okay, so administering the DLA. This may be something that you all want to ask Lynn about a bit more once I've finished up, since she's the one who led this and did all of this work. But what I will tell you, just so you have context in interpreting the rest of my presentation, is that the ratings used in this report, the staff were extensively trained in administering it and scoring it in a way that it was reliable. They were certified by the individuals who developed the scale and managed the training program. There was inter-rater reliability done to ensure that staff were reliably administering and scoring the scale. Because some of this can be somewhat subjective, if you get training, you understand how to rate the scale in the way that it was designed to be done. And if 2 people rate the same person the same way, we have a bit more confidence that it is being done reliably, meaning that if we got 2 more people to do it, they would likely administer or provide the same score. So residents were rated on the DLA at admission and again at discharge. There were some who got ratings throughout their stay, but there weren't enough to analyze. There was missing data, so I'm not going to present those data here. So the data come from 33 residents who came to the ranch between December 2019 and July 2021 and had complete data for both admissions and discharge. So you'll note that in there we do have the COVID pandemic. The residents had a mean age or average age of 28 years, ranged from 19 to 45, and were mostly male, 1 non-binary resident. So that you have some context for the data that I am going to show you. All right, so first I'm going to present data from global functioning. So when someone administers the DLA 20, you can get scores on each of the 20 domains, as well as an overall score taking all of them together. And that's global functioning, meaning we're considering all these domains of functioning together. The individuals who developed this scale suggested that an improvement of at least half a point from admission to discharge would be considered meaningful. So anything from 0.5 improvement to greater would be considered enough of a change that we would consider to be clinically meaningful. So for our sample, for those residents who had complete data, 29 of them, the average degree of improvement was 1.21 points, which you can see is much larger than the 0.5 threshold for significance. At the same time, there was a range. So some showed a slight decline in functioning to quite a large degree of improvement. So that's interesting. When we kind of see two things there. Most improved, but there was some variability. So that means that there's something to better understand there. The other thing to take away is that 75% of residents improved by at least 0.5 points. That's that recommended benchmark indicating program success of at least 35% of program participants. So let me unpack that for a minute. The scale developers said, okay, for someone to have improved, they should improve by at least 0.5 points. And then if you want to consider if your program as a whole is successful, you would want to have at least 35% of people doing the program to exceed that 0.5 benchmark. So they said you need to have at least 35% to say your program as a whole works. The ranch had 75%. So that tells us that yes, the ranch seems to be effective compared to these benchmarks from this scale. So that's good news. Now let's break it down a little bit more. So remember, it's the DLA 20. So there are 20 different domains, and these are considered domains relevant to recovery from severe mental illness. So there's a lot on this slide, so I'm going to walk you through it. So what we have here is a bar graph along the x-axis on the bottom are all of the different domains of the DLA 20. So you can see health practices, communication, managing time, productivity, managing money, and so forth. Hopefully you all can see this well enough to read those. If not, I'm sure Lynn can talk to you about what they are. And as well, I'm going to make sure that you all have these slides if you want to refer to them later. The other thing I want to point out is that on the next slide, there are going to be green and blue bars. We're starting with just the green bars because those are scores at admission. The other thing to look at is the y-axis. You're seeing there the scores on the DLA. Remember, they go from 1 to 7. On here, you'll see 1 to 5 just because there were no scores that went all the way up to 7. But that doesn't mean that they couldn't have existed. But since this is baseline scores, the scores were on the lower end as we'd expect. I also want to give you a sense of how high or low these scores are. So now what I added are ways we can interpret those scores. And this is what the scale developers suggest. Remember, a 5 to 7 indicates no impairment or very minimal. So that would be kind of I don't love the word normal, but normal score. Scores from 4 to 5 indicate mild impairment, 3 to 4 moderate, and 2 to 3 serious or severe. And so if you take those lines and take them across the graph, you can see that there was mostly moderate impairment at admission. And in my view, this is what we would likely expect. So an individual with very severe impairment is someone who would likely need to be in the hospital. So someone who's unable to dress, unable to bathe, things like that. So folks who get to the ranch are at a place where they are able to manage many of these activities of daily living, but not all of them and not all the way up to a level that would allow them to function easily out in the community. So I think we're seeing scores that one would expect, but then also quite a bit of room for improvement. A lot of the scores are in the moderate range of a functional impairment. So let's go to the next slide. This is going to be the more exciting one. And so what you see here, the graph got a little busier, but that's because I added in the discharge scores. And so those are the blue bars. And as you can see in all of the domains, the blue bars are higher than the green bars, meaning that functioning went up in all 20 of these domains. So that is very good news. And you can see that many of those domains got above a 5, meaning that people got to a level of functioning that is no longer impaired. So for example, grooming, that got all the way up above a 5. So there are many domains in which on average, individuals who come to the ranch are moderately impaired when they come and back up to normal levels of functioning that one would see among the individuals out in the community. So that is good news. At the same time, it's not completely easy to interpret, right? So what I did some additional analyses to better understand the size of the effect. So I gave you some sense of that by comparing the benchmarks, but the number itself of like a 4, you might say, Kim, well, what does that mean? So in order to get a sense of that, I calculated something called an effect size. And in particular, what I did was I calculated something called the standardized response mean effect size. Now, what that is what it does is it examines the average change for each person, but then also takes into account the amount of variability there is. And so this is useful as a way of indicating how responsive someone was to an intervention or a program. And so what I want you to keep in mind that an SRM, that's the abbreviation, of 0.4 or greater is considered the lower bound for clinically meaningful change in functioning from prior studies that have been published. So what I did was I calculated the SRM for each domain of the DLA. And what we want to keep in mind that 0.4 or above would be considered clinically meaningful improvement. And then I also calculated the proportion of residents who had at least a 0.4 for each domain. And there is a citation down there if you want to read more about this effect size. Okay, so change in functioning. There's a lot on this slide, but again, I wanted to make this available to you all to refer to later. So there's a bit more on there than you need to take in right now. So what do I want you to take away? The table on the right shows each of those domains on the DLA, and they're ordered by how responsive they were to programming at the ranch, meaning bigger effect sizes are at the top and then smaller effect sizes at the bottom. And so what you're seeing there is the domains that had the biggest effect. And so many of them were very, very large. So health practices, that would be things like managing one's health condition, like taking medications, things like that. And so what you see is the domains with the greatest magnitude of improvement: self-management of health conditions, communication skills, time management, productivity, meaning engaging in productive activities, money management, problem solving, and leisure skills. So those had very large effect. Some domains demonstrated lower degrees of improvement. And I'll tell you what those were. You can see they're ones at the bottom of the table. So appropriate dress, behavior norms, personal hygiene, appropriate sexual behavior, and substance use. Now, I don't want us to conclude that people at the ranch did poorly in those domains. That's not necessarily the case, because those were domains where people were doing better at the beginning. So there was less room for improvement. And so that might be one reason the effects weren't quite as large. So it's hard to interpret these scores. It can be hard to understand them completely, but as we take them in as an overall pattern, we can start to understand it a bit more. And so speaking of understanding it, I'll move to interpretation and conclusions. So going back to our program evaluation model, here we're back to step 4, which is taking some interpretation. What do those numbers mean? Drawing some conclusions and linking it directly to the numbers I showed you. So a question we might have: do residents at the ranch demonstrate improved functioning at discharge? I would say that our data here suggests yes. Results indicate that doing the programming at the ranch far exceeded recommended benchmarks for successful mental health programs for adults with serious mental illness. And what is the data that tells us that? The proportion of residents with clinically meaningful improvement on the DLA from admission to discharge of 75%. Next question we might ask: can we conclude that the SLR programming, and not merely passage of time, accounts for improved functioning? And I would say probably yes. So the gold standard for concluding something like that would be a randomized trial so that we can rule out alternative explanations. There are all kinds of things that it could explain away that finding. Things like the people rating the residents, wanting them to do better at follow up, or just the passage of time. Sometimes people do better with the passage of time. So we can't definitively rule those out with the results we have. That said, the profile of domains of functioning that appeared most responsive to change are those that can be directly linked to the programming. So let me unpack that a little bit. So when I'm talking about the profile of domains, I mean those the analyses I showed you with the bar graphs that were breaking down the global functioning into those different domains. And so remember, I said that the kind of idea of a logic model can help us as we do program evaluation. Well, this is where that shows up. So if you specify at the beginning how you think your program works, and then you see that those are the domains that seem to change, that can give you a bit more confidence that it's your program doing it and not just time. So, for example, I would argue that the domains with the greatest magnitude of improvement, meaning the largest effect sizes, are ones that you could directly tie to things that happen at the ranch. So, self management of health conditions. I mean, that's part and parcel of what residents do every day. They're being encouraged to manage their own health conditions, to keep track of all of those things. Think about productivity. They're getting engaged in a community in a productive way. You can also think about social rhythms getting regulated, getting up at the same time every day, doing work, things like that, as well as leisure skills. So we can think about how all the different things that people do in work crew and then in off time, how all of those things are likely to contribute to improvement in these functional domains. And so I would argue that at the very least, we can conclude that it's likely the ranch programming that can account for these outcomes of improved functioning. So I'm going to move on to another way of evaluating the program. So what we did in that piece was look at resident functioning as rated by staff at the ranch. And that's incredibly important, in part because when people are struggling with mental illness, sometimes they may not notice or fully appreciate some of those changes. So having an outside impartial rater provide information can be incredibly useful. It's also important to know what residents themselves think and what their families think. So that's where the satisfaction survey comes in. So what we have here are data from 62 residents. You can see from September 2019 to July 2023. You can see their demographics up there, and you can see that 82% of the respondents reported being very or extremely satisfied with the ranch. And so that's a nice high number that we would hope to see. What I broke down here are very similar proportions. So only 1% would not recommend the ranch program. So that's great to hear. And then 65% are very or extremely satisfied with the degree to which the ranch helped them develop skills to recover. We got very similar results for when it was specified as the work program. One that I found really interesting was a survey item that asked about how satisfied were you with the level of freedom that you experienced while at the ranch. This one I found interesting because unlike the prior questions, there was more variability. And when there's more variability there, that can sometimes give us clues for places where we might be able to improve something. So if everyone says it's all good, that's wonderful. And there's not a lot we can do there to improve. And we know we can always improve, all of us, all the time and almost everything we do. So when there's some variability there, there's something for us to work with and understand better. And so you can see that 23% were extremely satisfied with the freedom experienced, but we got a full 10% not at all satisfied. And I also was struck by this item as well, because if you think about what it's like to be in a psychiatric hospital, you really have no freedom And that's where a lot of people from the ranch may have come from. And so having some freedom is going to be really important for motivating engagement in one's own recovery. So I also did some analyses using what's something called a regression analysis, where I could look to see what are some factors that account for this variability in satisfaction. Um, and so I found that greater satisfaction with freedom experienced at the ranch, as well as greater satisfaction with skills gained, were both associated with greater overall satisfaction. So the idea there is, how do we make sense of these overall satisfaction ratings? What are people experiencing at the ranch that leads them to feel like they benefited more? And what this analysis suggests is that feeling like you have more freedom there and that you gained skills are both very important. And importantly, those analyses adjusted for age, gender, and length of stay, meaning that those factors likely can't explain that association. Interestingly, there were no clear changes in this item pre or during COVID, meaning that the proportion of people who reported satisfaction with freedom didn't seem to change a whole lot based on the timing. Okay, so the last thing I want to mention briefly is the family survey. Satisfaction was high. What you can see here is that satisfaction with communication was greatest for admissions, somewhat lower during the stay, and lower around the discharge process. Factors that led family members to select the ranch, not surprisingly, the natural setting was a big one, focus on work. Some people also rated continuum of care, importance of community, that it was recommended, and an alternative to approaches tried. So individuals were able to select as many of these that were relevant to them. So you can see that the numbers are more than the number of people who responded to the survey. Most valuable aspect for your family: recovery supports, better support, place to belong, respite, and creating independence for the family member. Finally, some future directions. So things that Lynn and the committee and I talked about doing would be getting resident perspectives. So we got staff ratings of functioning. What do residents say? What do they think about their functioning? What do they think about symptoms like depression? And what about quality of life from their perspective? And then getting both family and resident satisfaction over time. So we got admission and discharge. What about farther out? To examine durability of improvement. And then another thing would be great is that I presented all of the quantitative data, so all of the numbers. It would be great to link that with the qualitative feedback we have, so what individuals say in their own words, to help us understand the numbers better, so to bring those together. So I'm going to stop there and turn it back to Lynn to answer any questions that you have, and she can give you my contact information if you'd like to talk with me directly. Thank you for your time. I wish I could be there in person, and best wishes to all of you.